This is the second of a series of lectures on the management of the geriatric patient, particularly with reference to the surgical patient who is undergoing procedures. We oftentimes wonder about the role of the podiatric physician in general medical management of these patients. I've seen some arguments that you're not an MD, and therefore you really don't have a full picture on these patients. And I would argue that the old phrase, a half doctor near is better than a whole doctor far away, is probably true. I think all of us see geriatric patients that are under less than perfect or ideal management. And I think when we take the responsibility to perform a major procedure on these patients, that we also have some responsibility to look at that patient generally. This perhaps summarizes the daily life of many of our geriatric patients. So the picture in front of you was one of my professors at the Pennsylvania College of Podiatric Medicine, Dr. Arthur Helfand. If you're not familiar with Dr. Helfand, it's because the years have passed. Dr. Helfand was perhaps one of the greatest instructors and teachers our profession ever had. He was a president of the American Podiatric Medical Association, highly published, highly recognized as authoritative as in the area of geriatric medicine and public health. When I was a student at PCPM 1969 through 1973, Dr. Helfand again was one of my professors, and even at that time he was recognized nationally as and internationally really as an authority on geriatric medicine. And he used to talk about the future of this profession in the early 70s, and he would say that the future of this profession is going to be geriatrics and diabetes, and that the demographics were such that that is where podiatry would be active and making its bones. And I used to laugh and I used to think, what does this guy know? Geriatrics and diabetes. And frankly, at that time, podiatrists were not intimately involved with treatment of the diabetic patient. But we now know that the population greater than age 65 is the most rapidly expanding segment of our population. This is going to double over the next 30 years. And here again, it's inevitable that podiatrists will be intimately involved in evaluation and treatment of the geriatric patient. And it would behoove this profession to look carefully at the problems that exist with the geriatric population and move in that direction to develop expertise in the area of geriatrics. This is something that is not unique to any one particular area. Obviously, some parts of the United States are aging a bit more rapidly than others, but this is something that's going to affect our profession. So the general considerations in treating the geriatric patient are that over the age of 70, the average patient has 5 or more comorbid conditions for which they are being treated. And with advanced age, not only do we have increasing numbers of comorbid conditions that can complicate our treatment of the lower extremity and have manifestations in the lower extremity, but it also contributes to really poor functional status, so that it behooves us to start looking at patients for balance problems, examining patients for the presence of entities such as vascular disease, not only arterial but venous, the effects of osteoporosis, the fact that with cognitive decline patients may not be able to follow directions that we impart on them for care of their lower extremities, and many of these patients have limited home support. So we need to look at these patients and the fact that as we get older, the incidence of diabetes-related problems increases. We have problems with edema and vascular disease and so forth. So what is the goal of the podiatric physician with reference to the geriatric patient? Well, the first is to recognize the risk of complications associated with aging. And this means not only familiarity with dermatologic and vascular and musculoskeletal and rheumatic and so forth conditions that affect the foot, ankle, and leg, but also taking the patient to the operating room for surgery. Anesthesia risk has to be appreciated, and looking at systemic complications. We want to take all this into account and come up with a management plan that decreases a risk to the older patient. Unfortunately, we cannot eliminate all risks, but we can do what we can to try to decrease the incidence of such complications. And that means that you assess each patient individually and not by age. So we don't stratify risk by age 60 to 70, 70 to 80, but rather look at that patient individually and discussing the benefits and for surgery, the potential risks in performing surgeries, alternatives, and the risk-benefit ratio, and documenting these discussions. So understanding the goals of treatment, particularly surgical treatment, in the elderly patient requires communication between the podiatrist and the patient and the caregivers who are identified, or various family members. And we want to find out the patient's preferred goals and treatment preferences. And at times this may not be the same goals or preferred treatment preferences of our patient. I recently had an older patient come in for a second opinion, and an arthrodesis of the first MPJ had been recommended, period. The patient had had a failed chylectomy by an orthopedic doctor. The doctor was now recommending fusion. Now, the patient was a post-clubfoot patient, had quite a few problems remaining on the contralateral foot, and really did not want to undergo arthrodesis. And certainly this was a reasonable choice in this patient. So we discussed alternatives that would be acceptable, such as resection arthroplasty or implant arthroplasty. And an honest discussion with the patient was that, look, implant arthroplasty is not likely to restore great range of motion. In any event, it may be helpful for relieving your pain, but there are certain complications and sequelae that go along with an implant arthroplasty or a resection of the joint, just as there are potential complications and sequelae with an arthrodesis. And it was the patient's preference that an implant procedure be utilized, understanding clearly that there were limitations to what you could or could not do. There have been changes and recommendations for fasting in the elderly patients. We'll talk a bit about that in a moment. We certainly want to review medications, and this is very important in the elderly patient and the management of their medications in the perioperative period. We want to review post-operative care. We want to find out, can the patient self-care? Do we need to recruit home nursing care, physical therapy, some type of assistance? Is there a caretaker? Are there family members? What is it that we can do to assist in helping the patient and avoiding complications? Included in this is our efforts to reduce the use of opioids. We want to avoid delirium and functional decline in these patients. We want to ask some questions about their living conditions. How many steps are at home? What's the lighting like? How much clutter is there? Can they use a wheelchair? Can they get around their residence? We want to assess their current ambulatory status and talk about their ambulatory status following surgery and what type of assistance they're going to require. So we have this, if you will, immediate preoperative checklist. And again, we want to make it clear that we understand the patient's goals and preferences. We want to confirm who it is that we need to contact in case there are problems and who's going to be assisting that patient. You want to consider a shortened period of fasting prior to surgery. You want to always use best practices regarding antibiotics and DVT prophylaxis. You want to make sure that non-essential medications have been discontinued, and conversely, you want to make sure that medications that are required are being taken. And you really want to discuss the patient's values because these are going to be important, such as our poor lady here who has difficulty with vision. This can impact on the ability of the patient to change dressings, to get their post-operative shoe or boot on, to be predisposed to falls and so forth and so on. So some examples that crossed my office in recent years: a patient with terminal cancer who had a failed transmetatarsal amputation and wanted to die with his foot on. And he understood he was at risk for sepsis. He understood that he probably had a foot that would never heal and was certainly at high risk for complications, but it was his choice not to undergo leg amputation. It was his choice to attempt to prevent sepsis and die with that leg attached, and indeed he did eventually die with his TMA actually almost completely healed, and was successful in obtaining his wish of not undergoing an amputation. We had a recent malpractice case which had settled here in Missouri, and it was a 71-year-old male who had dry gangrene of a toe that required amputation when it began to become a little bit soupy and a little bit painful. The podiatrist recognized that the patient had significant cardiovascular risk factors, referred the patient back to cardiology, and cardiology had cleared the patient for a limited anesthesia experience. Unfortunately, that clearance letter was sent to the hospital, never made it to anesthesia. Anesthesia elected to perform a procedure with sedation, and unfortunately the patient developed a pulmonary arrest and died of complications. So that complications can occur from even rather simple procedures such as that. I have a patient that I see periodically who underwent a failed triple arthrodesis by an orthopedic foot surgeon. She had massive open wounds and ulcerations in the presence of vascular disease and was certainly at extraordinarily high risk for complications such as sepsis and loss of her leg. She refused to attend any wound clinic. She refused to undergo revascularization. She refused any attempts at reconstruction of her deficits, and more or less felt that enough was enough and was content just to monitor this foot with periodic examinations and efforts to prevent sepsis. So at times, again, we have to appreciate autonomy. The patient needs to understand the risks and benefits of therapies, but ultimately we have to respect their decision making. With regard to preoperative fasting, historically all of us were raised to write orders NPO midnight. However, we can shorten that in our older patients who are more prone to dehydration, and it's been shown that really you could shorten that clear fast up to 2 or 3 hours prior to surgery with no increased risk. The current ASA guidelines for non-emergent surgeries allow us to have the patient take clear fluids such as water, clear tea, black coffee, juice without pulp, up to 2 hours prior to surgery. A light meal such as toast, non-human milk, cereal, applesauce, soup up to 6 hours prior to surgery. However, if we get into more traditional foods that can be problematic, such as fried foods, fatty foods, meat, and so forth, then we want to have fasting back to at least 8 hours. But in our elderly patients in particular, we want to go ahead and shorten the fasting if possible. Antibiotic guidelines do not call for specific prophylaxis in the elderly patient. We generally are going to follow the usual guidelines recommended by organizations such as the Infectious Disease Society of America or the Surgical Infection Society or the American College of Foot and Ankle Surgeons. And remember that the use of antibiotics is not age dependent. However, the dosage and selection of antibiotics may vary depending on certain comorbid conditions. For example, renal dysfunction, hepatic function may make a difference in antibiotic selection or antibiotic dosage. With reference to DVT prophylaxis, we know that older age does confer additional risk factors for DVT, and you want to look at that patient, ask about any history of DVT, any history of coagulation disorders, and conversely, any risk for bleeding in these patients. And again, follow standard guidelines as recommended by the American College of Foot and Ankle Surgeons or the American College of Chest Physicians, and determine whether or not prophylaxis is required. But the mere fact that a patient is older is not a mandate for DVT prophylaxis. Patients who are under care for cancer do have a known higher risk for DVT. Certainly patients that have a history of prior DVT, patients that have significant chronic venous insufficiency, patients with CHF, patients with a history of smoking, obese patients, patients who are going to be immobilized for a prolonged period of time, patients that have these additional risk factors. We do want to look at these patients, assess them for any history of clotting disorders like protein C or protein S, some thrombophilia, factor V laden, and so forth, and either make a decision for prophylaxis or refer them back for consultation to their primary care physician or cardiologist, whoever you think is appropriate to share in that decision making. The use of anticoagulation is a bit easier these days, as we now have a number of agents that we could give by mouth that do not require monitoring for keeping that patient in therapeutic range. So this has certainly made the job of DVT prophylaxis a lot easier, although the expense is something to be considered. Now, with regard to perioperative medications for thyroid and blood pressure and so forth, you might say, that's not my job, Mon. Well, then whose job is it if it's not yours? So someone needs to look at the medication list and determine what should be taken, when should these things be taken, when should these drugs be stopped. And this can be done in several ways. One can refer the patient back to their geriatrician or their primary care physician or whoever is responsible for these things, or you can look down that list and make appropriate recommendations. You want to remember that many of our patients are taking herbal agents and vitamins and supplements, and these things can have significant effects not only on your surgery but certainly on anesthesia. Drug interactions are certainly possible with a number of these herbal agents and supplements and so forth, so that it's important to make sure that where the patient lists their medications, that they have remembered to list any herbal agents, over-the-counter products, and so forth, because not infrequently patients don't consider these to be medications and forget to list them. You want to look at medications that can have serious effects when withdrawn, and while you want to discontinue non-essential medications, you want to look carefully at their cardiac meds, any anticoagulants that they're taking, remembering that you can have rebound, increased risk of thrombosis, any anti-seizure medications, and so forth. So a plan should be in place and discussed with the caretaker or relatives caring for that patient with regard to management of these drugs in the perioperative setting. These are ways to avoid potential complications, or at least minimize the risk of potential complications. Intraoperative management, anesthesia, of course, will generally look at the patient, evaluate the patient individually, and decide on the appropriate anesthesia approach. As the captain of the ship, as the surgeon, you want to ensure patient safety in the operating room, and with aging comes frequently loss of padding around nerves and various osseous prominences, such as the greater trochanter. So we want to make sure that we're doing the best we can to attempt to minimize the risk for nerve injury and pressure ulceration. We want to think about post-operative pain management, and generally multimodal approaches are best. Blocking pain at multiple levels, trying to minimize the amount of opioids that we are using. There has been some recent emphasis for increased use of regional anesthesia, and certainly we want to look at the patient's potential for nausea and vomiting, risk stratify these patients and ask anesthesia to provide appropriate prophylaxis when important and necessary, and prevent pulmonary complications as much as we can. I mentioned there has been recent considerations for regional anesthesia in the geriatric patient, and that is something we'll talk about in a bit. Falls following surgery are not uncommon. It's estimated that about 1/3 of patients who undergo surgery fall following surgery. This results in a considerable number of hospitalizations, so that patients should be assessed prior to surgery with regard to the risk of falling. And again, you want to look at that patient and see whether they have, before surgery, impaired gait, impaired mobility. You say to yourself, what's this patient going to be like following surgery with their foot in dressings or a cast or a boot or a shoe? You have the effects of pain medications that can cause a fall, or other medications in combination, creating an additive effect with their postoperative analgesics. You have some patients that may have some altered mental state pre-op or post-op. You want to look at their home environment. Patients that have neuropathy, particularly sensory neuropathy, visual impairment, these things can contribute to falls. Dehydration is a known factor contributing to falls. And of course, the patient getting up during the evening hours and visiting the bathroom. This is, again, a common cause of falls in any event, let alone when the foot's all wrapped up in a cast or a splint and dressings and so forth and so on. So the patient needs to think about how they're going to get around following surgery when they're older, when they're in the hospital. Also, we want to familiarize the patient with their environment, use of their call light. They want to keep the patient's possessions within reach. You want to make sure that the bathrooms and ambulatory ways are reinforced with bars and so forth, handrails. And if you have a patient whom you think is at risk, order the bed to be in a lower position, raised to a decent height only when transferring. Make sure that all the wheels are locked and we have non-slip, well-fitting footwear. Keep the operative area, or the post-operative area, and the home safe and uncluttered. There are many, many risk scales for falling that you can use. Some are simpler than others. This is the Morse Fall Risk Scale, and what you do is look for a history of falling. If the answer is yes, then it's scored 25 points. You want to look at diagnoses with which falls can be associated. If the answer is yes, that's an additional 15 points. Does the patient require an ambulatory aid? And depending on that type of aid, additional points are given. Is the patient receiving IV therapy? For example, the patient that has osteomyelitis and is receiving antibiotics. Looking at the state of their gait, is it normal? Is it weak? Is it impaired? Again, points are awarded. And looking at the patient's mental status, points are awarded. You then tally up the score, and greater than 45 is a high-risk patient. Below 25 would be considered a low-risk patient. So there are rather simple scales that one can use in order to determine the risk for falling. Again, the active geriatric patient out in the community doing a good deal of walking, reasonably healthy, tends to be at somewhat of a lower risk. As far as efforts one can do to try to prevent these falls, certainly you can order balance and gait training pre or post-operatively. Physical therapy can be ordered. You want to have the patient utilize an appropriate mobility or balance aid. You want to assure that they have adequate lighting. Again, you want to make efforts to reduce opioid use and use a more multimodal, balanced post-operative analgesia regimen. Make sure the patient is drinking fluids or receiving fluids and not becoming dehydrated. I ask patients to rearrange things where they're going to sleep and so forth when necessary in an effort to minimize the use of stairs. Recommend that the family declutter the home environment, if you will, and again, utilize family members and friends. As far as anesthesia goes in the older patient, this is, of course, a decision that's going to be made by the anesthesiologist and nurse anesthetist. And overall, we don't have good evidence to suggest or direct us to the, quote, best anesthesia for older patients. Again, we know that we should minimize the use of opioids following surgery, particularly over the age of 65. Complications of opioids in the older patient include respiratory impairment, circulatory impairment, and a particularly bad problem is that of delirium. Nausea and vomiting are not uncommon with certain analgesics. Constipation is definitely a problem. Increased fall risk, a definite problem. So in using opioid analgesics, you may want to recommend a stool softener or a bowel stimulant together with extra fluid intake in an effort to avoid these problems with constipation. These are not at all uncommon problems in the geriatric patient. It's been said that there are certain drugs that are best avoided in the geriatric patient because they're associated with increased risk of complications. This includes analgesics such as Demerol and Talwin. It is said that we best avoid non-COX-2 anti-inflammatories, non-benzodiazepine hypnotics, as well as benzodiazepines and barbiturates. The use of Talwin generally has been recommended to be avoided in the older patient, and if possible, avoiding skeletal muscle relaxants. Getting back to this issue of regional anesthesia for a second, we don't have any good data for foot or ankle surgery. Most of the data and enthusiasm for regional anesthesia has been derived from studies on vascular surgery and hip fracture and total hip replacement, total knee replacement. We want to remember that the response to regional anesthesia with sympathetic blockade may be exaggerated in elderly patients, so that hypotension can be a problem. It's not that regional anesthesia is a slam dunk, absolutely safest for most people. The advantages of regional anesthesia are obvious, including reduced postoperative pain, reduced sedation with regional versus general. Obviously, we're able to reduce the tracheal intubation time and the need for any mechanical ventilation. There's quicker return of GI function with regional anesthesia, with sedation, and the risk of postoperative myocardial infarction is lessened. So generally, cardiopulmonary, cardiovascular complications are less with regional anesthesia. The disadvantages, again, in the elderly patient, there's increased sympathetic sensitivity, increased risk of urinary retention, hypotension, and increased risk of pruritus. So is regional anesthesia the ultimate answer for the elderly patient? And there's really no definitive evidence that regional anesthesia is superior when compared to general anesthesia when used as the primary modality for the older patient, and there certainly is very little data with regard to foot and ankle surgery. The Cochrane database recently reviewed this issue of regional anesthesia and felt that most of the studies were somewhat controversial, particularly with reference to the quality of the studies. And again, ultimately, with the geriatric patient, the decision for best anesthesia is based upon consultation with the surgeon and the surgeon's needs, the anesthesiologist, and the primary care physician, so that each patient needs to be individualized with regard to their risk factor. As far as postoperative nausea and vomiting goes, you might ask about a history of motion sickness. We know that opioids can be associated with nausea and vomiting. Generally, it's more common in younger than older patients. It's more common with general than regional anesthesia. The longer the general anesthesia, the more likely nausea and vomiting are to be a problem. There are specific guidelines that have been forwarded with reference to the treatment of nausea and vomiting in the older patient. It's been advised that we avoid anticholinergic agents because of the increased risk for cognitive impairment and for delirium. Other agents can be associated with gastroparesis and associated constipation. Delirium can also be worsened by the use of corticosteroids. As far as nutritional considerations go, we know that deficits are common in the older patient. It's important that you ask the family members or caretakers to make efforts to avoid dehydration at least for the first 5 days following surgery. If the patient is in the hospital or at home resting their foot, make sure their dentures are easily accessible. You want to recommend that the patient sit up in bed when eating and remain sitting up for 1 hour following meals. And take a look at the patient, and if they have evidence of dysphagia, then if they say, you know, I have food that sticks in my throat all the time, or if they're drooling, then you want to take special precautions to make sure they're not at risk for these problems. Oral nutritional supplementation, we see a variety of vitamins and supplement packages being advocated for perioperative care of patients. These seem to be more indicated when the patient appears to be malnourished or is malnourished, patients with dysphagia, patients with dementia who have poorer diet and are more likely to have a need for nutritional supplementation, or following procedures that require prolonged care and healing. As far as pulmonary complications go, for the patient that's going to undergo a major procedure, fracture management, Charcot joint reconstruction, and so forth, we know that older patients are at greater risk for hospital-acquired pneumonia, anaphylactosis, and acute respiratory failure. Make sure, again, that they're sitting up and when they're eating, and sit up for 1 hour following eating to avoid aspiration pneumonia. Have the patient perhaps sit up, sit in a chair, get out of bed when eating. You might consider ordering chest physical therapy or incentive spirometry or deep breathing exercises. One of the real problems in the elderly patient that gets a lot of attention is that of delirium. And I have seen this several times in my career, where a patient has been hospitalized for treatment of an infection and is hospitalized for quite some time, and one sees an acute decline of their mental function, and all of a sudden the patient changes a good deal, and you're wondering what has happened to cause this acute cognitive decline. This can have an acute onset, fluctuating course, and you want to think back and say to yourself, is this the way the patient was when they came in? Does the patient all of a sudden seem to be rather distant and not attentive to your discussions with them? Is the patient suddenly having difficulty focusing on attention? Is their thinking disorganized? And again, we go back and think to ourselves, what was this patient like when they first came in to the hospital? Because delirium is something that can be quite serious and something that we try to avoid. The causes can be many. At times, delirium may be associated with uncontrolled pain. It may be due to hypoxia. It may be due to uncontrolled infection. There may be an electrolyte abnormality. In my experience, oftentimes it is caused by either hypoglycemia or medications with which the patient is taking. So that if you note this sudden change in mental status, think about the drugs, think about their glucose level, see whether or not they appear to be in significant pain, and take appropriate action and utilize appropriate interventions. Postoperatively, our evaluation of the geriatric patient really is not that much different from the non-geriatric patient, recognizing that they are at increased risk for problems such as pressure ulcer formation if they are not properly prophylaxed, increased risk of nutritional problems, increased risk for functional decline, looking at them for fall risk, and again watching for any acute change in their mental status. So the geriatric patient does require special consideration. The geriatric patient does require special concerns. We certainly cannot eliminate all complications and sequelae that can occur in performing surgery on the geriatric patient. However, we probably want to do what we can to minimize risk to the geriatric patient. It turns out in hindsight that my old professor, Dr. Arthur Helfand, was indeed correct. And he knew back in the 60s and early 70s that indeed the future of this country was going to be diabetes and geriatrics, and so right he was, and that this profession would be deeply involved in caring for the geriatric patient and caring for the diabetic patient. As a profession, we've done a lot to become involved in evaluation and management of the diabetic patient. I think it's time we take a second look and seriously begin involvement in treatment of and evaluation of the geriatric patient. So Dr. Helfand, this bud's for you.